on health more widely, and how the pandemic's impacting our health both directly and then indirectly. And I think there's been a lot of discussion over the past year about everything from undiagnosed cancer to the impacts on obesity to how the pandemic might be impacting things like alcohol and drug use. I think there's all sorts of questions around what's going to be the state of health inequalities as we emerge from the pandemic, and what might be some of the longer term impacts of the pandemic on public health. I'm going to keep my contribution to this very brief because I'm by far the least interesting person on this panel. We're joined today by a really great set of speakers. So we've got Professor Vital Katikareddy, who's a Senior Clinical Research Fellow and Honorary Consultant in Public Health at the University of Glasgow, Dr. Jennifer Dixon, Chief Executive of the Health Foundation, and Joan Sadler, OBE, Director of Partnerships and Equality at the NHS Confederation. Just a couple of housekeeping rules before our panelists make their contributions. This event is being recorded, so please bear that in mind when you ask your questions. They might come back to haunt you and Mr. Putin and Mr. Jong-un will have an opportunity to review them in the future. So just bear that in mind. And secondly, if you do want to ask a question when we get to the Q&A element of this discussion, you can do so using the Q&A or the chat functions in Zoom, which it should be at the bottom of your Zoom screens. So without further ado, I'm going to hand over to our panelists to get their thoughts on this topic and their contributions. So Vital, I'm going to ask you first to make your contribution, please. And I believe you've got some slides that you want to share with us.
Yes, I do. So just get them up. Okay, so I'll try and go through this fairly quickly and stick to time. So it's a real pleasure to be able to speak to you today. What I'm going to try and do is suggest that the UK has had a relatively bad pandemic until at least quite recently, and much of that is actually driven by what was happening beforehand, so even pre-pandemic. So if we look at the risk of dying from COVID across different countries, so this is accounting for population size, we usually see that the UK is close to the top of most league tables, so not a good position to be. And why might that be? Well, what I'm going to suggest is many of the things that were happening before the pandemic meant that actually our public services and our health system and other important parts of society for kind of protecting us against the adverse impacts of the pandemic were probably not in as good a place as they could have been. We'd had a decade of austerity, and what we'd seen even before the pandemic was that life expectancy, which had been improving since the Second World War, had begun to stop improving. And in terms of things like infant mortality, in some areas had started to get worse, especially in areas of deprivation. We also had a couple of important threats in terms of political threats, but also how we might get distracted from responding to health emergencies. So issues like Brexit and the climate emergency meant that we might not have been as prepared as we needed to be for an upcoming pandemic. And then during the pandemic, we've had issues of uncontrolled infection, so very high infection rates, which have to some extent necessitated quite severe controls on society and non-pharmaceutical interventions, so lockdown measures and things like that. And the mixture of those two have led to severe economic, healthcare, educational, and social disruption. And throughout all of these disruptions, but also tracking from before the pandemic, we had major inequalities in these issues by ethnicity, gender, age, socioeconomic position, but also across lots of other dimensions. So we can think about inequalities, but in relation to disabilities and so forth. Now, this is a bit of a horrendous slide. for which I apologize, but the main thing that we're trying to emphasize here is, of course, there's been a lot of health harms that have been directly related to the infection. So those are the things in purple on the left. However, separate from that, there's been lots of harms that have arisen due to broader disruptions. And that's partly because of the high infection rates and partly what government has needed to do to try and reduce those high infection rates. And some of these adverse consequences, such as people having had to stay at home and miss schooling, miss education, perhaps not having been seen for preventive healthcare and so forth, are likely to have quite long-term consequences. So the health consequences are not just going to be related to COVID deaths, but unfortunately, probably increased risks from cancer and other diseases longer term. So as we're hopefully at some point in the future beginning to think of what might happen after the kind of really acute phase of the pandemic, some of the big risks that are on the horizon is major macroeconomic disruption, so potentially a recession, and we know that that itself can have big impacts on health, especially mental health. Many people have had delayed life transitions in terms of forming partnerships with significant others, moving into their own home, all of those types of things. But also young people entering the labour market are likely to have difficulty getting a job, which then might have long-term consequences on their career and also their health. The longer-term impact of COVID could well lead to long-term disability in terms of things like long COVID. And I think there's a real risk here of a return to austerity, which could exacerbate the health consequences. And we must remember other policy priorities like the climate emergency as well. So hopefully we'll be able to build back better. That's certainly the mantra at the moment. But when we're doing so, we need to think about how we have a strong focus on addressing inequalities. We need to try and mitigate some of the harms that have arisen so far in terms of disability, but also the healthcare disruption and so forth. And we need to think quite carefully about how we respond to the economic crisis and the climate emergency as well. So I've tried to give you a fairly brief overview of what I think are some of the important issues, but hopefully that kind of sets the scene for further discussion. Thanks.
Great, thanks, Vital. That certainly raised a number of questions for me and some interesting points there. So Jennifer, over to you and your thoughts.
Thank you very much, Scott, and very nice to be here, and good morning, everyone. I, like Vital, just going to mention four things, really, four clumps of things which I think might help in the discussion and set the scene a bit. And they've all got a health slant because of my background. So the first clump is the background health picture, and I think Vital set that out really, really nicely. The pre-pandemic picture of the health fabric of the nation not being as strong as we would like, in particular stalling life expectancy, we know that, and the possible impacts not just of austerity 10 years, but also longer run structural economic effects that Angus Deaton is looking at with respect to the IFS Commission, and has done in the US as well, looking at long run changes in industrial society, which has crushed certain communities. Then we have the pandemic sprinkled on all of that, and the effects that Vital has really nicely brought out, both the direct impact on illness and death, but also the indirect effects as a result of the financial squeeze and stress on some people and schooling and so on and so forth. And the only thing I want to bring out there is that some very nice IFS work showed that the immediate impact of the pandemic on places was not necessarily the same as those suffering long-term left behind problems. So cities have really been crushed mostly by the pandemic, whereas other places are suffering long-run endemic problems, and they're not necessarily the same. So that's quite interesting in terms of health. And then, of course, we've got post-pandemic health issues that Vital, some of which he pointed out, long COVID, the ill health shadow that will extend into the future because of the stress and the insult, but also, of course, the big, huge backlog for the NHS and whether or not it can cope with pent-up demand that is not actually as a direct result of COVID, but actually is to do with backlog of waiting. So that's the sort of contours of some of the health picture we could explore. The background economic picture is the next clump. And just to say, obviously, just some obvious contours. We've had 10 years of austerity, which has really eaten away, hasn't it, at the fabric of some of our social and local life. We have got an enormous, what is it, £300 billion plus bill as a result of the pandemic and mounting. We've had quite a lot of fiscal activism. Government has been able to have room for manoeuvre here, as we know, but that's been entirely supported by a very conducive monetary policy. We've had a lot of QE and low interest rates, and that may not necessarily extend into the future. And I think most of the economists I'm reading about say that we've got maybe 2 years of recovery to have, and then we'll have to start thinking about paying some of this back because of the risk of higher interest rates in future, which will stump up debt interest payments. So that's the kind of thing. And then the third clump is the background political picture. We've obviously got a government majority until 2024 or even 2023, depend on how the politics goes. We've also got the disruption of Brexit, as Vital mentioned. We've got the pandemic shock that we've mentioned and the levelling up agenda. We've also got a background of the industrial strategy that Prime Minister May produced in 2017, which has now been superseded by a plan for growth, which has got levelling up all over it. I'll come back to that in a minute. And also the background political picture is we've got an incomplete agenda, and that's an understatement, with respect to the centralisation of national government over local government, considering a lot of health is generated in local government because of local spending. So all the Devo agenda and the mayors and all the rest of it and the number of local authorities, that's still unfinished business, which is important to think about with respect to health, because the NHS is only a small factor influencing health compared to the wider. So that's my third clump. My last clump is just, well, what do we now need to address? And I think there's just some headlines here. So the first thing, as we try and recover, if you look at the plan for growth, which is the government's centrepiece on levelling up at the moment, there's a real cognitive bias throughout that, which is towards infrastructure, and it's towards economic prosperity. It is not towards health capital. There's a bit of green capital in there, but not really in terms of the four capitals. So there's a cognitive bias. We need to get much more in the conversation that health is important to wealth, and that needs to be leavened throughout policies. So that's the first thing. It's not just a question of just try to get more infrastructure and prosperity and health will flow from that. We know that doesn't work. Health is important for future prosperity. So that's point number one. Point number two, we need a proper strategy for tackling the wider determinants of health. We haven't got one. There's lots to be said about that. I won't bore on about it now unless people are interested. But we really need to think about local government's role in health and fund that. We need to think about employment and good work. It's taken Uber drivers and Asda workers to get into the courts. The government isn't active in that respect to try and protect workers who need, because employment really affects health. We need to be measuring health capital independently outside of government, I think. We at the Health Foundation funded Michael Marmot's reviews, 2 reviews in the last year. It took us, an independent foundation, to do it. Why isn't that being done externally? If it's such a precious asset for wealth, how can we just look at that more carefully and independently? A couple of other headlines to finish. The first is obviously another is the NHS. The NHS obviously needs to play a major role in recovery with respect to the pent-up demand that is stacked up as a result of the pandemic. But it is also, so it needs to be invested and needs to grow to try to scale up its faster productivity with respect to diagnosis and treatment, but also it is £140 billion industry, Britain's largest. It has a big role in health generation. So we need to really think about its role as an anchor institution, I think. And then two quick more things to address. The second to last is, if we're really, really serious about health capital and improving the fabric of the nation's health, we need to think more beyond the short term and really have long-term commitment to a proper strategy to influence health. We've got far too much short-termism, and that's riven throughout policy. So what would a long-term intelligent strategy for this asset look like if we claim we want a prosperous Britain? And then finally, just because this is an UKRI funded sponsored event, we also really do need to take a hard look at the kind of research distribution of funding that we have on health, and to see that it is appropriately balanced towards looking at the wider determinants of health and what is exactly eroding our health fabric, as well as looking at downstream science and treatment of disease, and indeed vaccine development, which is all very important, but we need a proper balance. And that requires, again, correcting a cognitive bias that actually health is impacted on far more things than healthcare and science. So sorry, that was rather long, but that's my manifesto, I can perhaps put it that way, and hope that's helpful in terms of discussion.
Indeed it was, Jennifer, thanks. That was some really interesting points there. So Joan, over to you, really interested to hear your thoughts on this.
Okay, well, we're in fours today. I'm thinking in fours as well, Jennifer, and if I start with the first one. So again, good to restate Marmot's, both his first and second report. Why are the Health Foundation having to fund a report 10 years later that is kind of restating a worsening position? So if we think about some of the key points in there, the deprivation and the shorter life expectancy were marked by regional differences, right? So again, coming back to the north-south divide, what does it mean post-COVID, not just in terms of what we're hearing in economic terms, but in health? You know, where do we build a strategy that puts well-being as well as health at the center and has cross-government support? It's really quite important. He also talked about mortality rates for men and women aged 45 to 49, with so-called deaths of despair, suicide, drugs, alcohol, post-COVID, what will that look like? And he also talked a lot about child poverty, as well as housing crisis, insufficient money, and ignored communities. A report that we've just produced at the NHS Confederation, actually was published in December, talks about those ignored communities, effect of COVID, as well as those communities we already know about and haven't done anything about. How do we make sure we're still not ignoring them? Because actually, we can't do that. I was going to say can't get away with that. Why would we want to get away with that? So if I think about using the phrase that goes to my second question, we don't want to get away with not investing properly. Our health budget in England was around 150 billion, 2019 to 2020. It's now over 212 billion. That's a boost of 60 million for COVID costs. Yeah, we need the money. The money has to be spent. But such spending on healthcare, traditionally, the 150 billion, has given us the kind of health inequalities that we've heard about today. So what is it that we're actually investing in, and can we start changing that? We are investing in inequality. Not great, but how do we start to then look at the real issues of placing both well-being and growth within our strategies for the way forward post-COVID? And just on that, and it's the only thing I will say, renaming the problem or the communities affected won't solve it. We actually need to do something that is long-facing, that it takes some bravery to say this is not a quick fix. And that's bravery from the health sector, those governing organizations, as well as clinicians working in partnership. So that leads to the third thing. We had this thing called the Atlas of Variation. Many of you remember, it's probably the precursor to GIRFT. getting it right first time, that program. It aims to bring transparency to best practice interventions. So they would state that variation is caused by population differences and the kind of factors of the practices of clinicians and the practices of healthcare organizations in healthcare. Interesting that we've got practices of clinicians and practices of healthcare organizations as two separate but aligned problems. And the plea there would be to, why don't we continue to do what the three key things emerging have asked us to do for a long time and continue to do, which is to tackle over or underuse, those interventions that will or will not improve care. Can we just get to grips organizationally with focusing on what works? And this is where the governance of our organizations in the NHS and across systems, as we're moving to, becomes pretty important. They also say that they need to practice preference-sensitive care, so things like shared decision-making, working with people, working with communities, again, has shone a whole light on how we have some deficits in our system, as has been seen through COVID, that lack of engagement, that lack of trust, that lack of community support is where we are starting to go now. And thirdly, the need to deliver better value that links under and overuse with preference-sensitive care, link all of that to spending. So there are some things that we need to do that will be complicated, not quick fixes. I think they again give us an insight as to how the health sector itself can start to reduce some of these health inequalities without saying it's too big, we don't know what to do. Lastly, I'm just going to restate what Marmot said before I end. He said that we endorse today what we wrote in the Marmot Review 10 years ago. Health inequalities are not inevitable and can be significantly reduced. Avoidable health inequalities are unfair. Putting them right is a matter of social justice. So are we interested in that social justice? Social justice, inaction that cannot be afforded for the few, inaction cannot be afforded, the human and economic costs are too high. So one is, do we think it's all right to continue investing our money? And that's just England's cost. I mean, we're over 230 or 40 billion across the UK. It's a lot of money. How do those invest? How do we start to invest differently and use the local levers coming through things like ICBs, integrated care, boards, integrated care partnerships to do our part in health, linking, as we've heard Jennifer say, that concept of anchor institutions, the public sector bodies, which are where most of our staff work. They're community members, they work in health. If we don't start doing things very differently, we will soon find that impact on staff then starts to take a toll, even more so on our healthcare system where we don't have the staff to keep it going. So those are just some of my thoughts.
Great, well, thank you very much, Jane. So now we've heard everyone's thoughts. We're now over to the Q&A session of this panel event. So please do drop in any questions you have into either the Q&A function on Zoom or the chat function. Before I hand over to audience questions, I had a couple of sort of questions of my own that I wanted to put to the panel. So the sort of the economy and how it impacts public health was sort of mentioned by each of you. So one of the things we're quite interested in at the SMF is how COVID might lead to some pretty permanent changes in the nature of the economy, and in particular we're quite concerned about how the pandemic is going to accelerate the decline of the high street. So the increasing shift to online retail and how that might decimate town and city centres, and then also the trend towards more home working. And I guess a hypothesis I might have there is this could have some negative impacts on mental health in particular, also physical health. If remote working means that we're getting less physical activity, but in particular, do some of the economic changes from the pandemic really risk exacerbating some of the mental health issues and some of the mental health inequalities that we already see in the UK? So I'd be very interested in your thoughts on that. If anyone wanted to go first on that question. Jennifer?
Well, maybe if I can make a start, I'm sure my colleagues will add more. I mean, I think there are two things as far as two big things, I think. One is the move to virtual working, as you say, and the other is the inevitable destruction of smaller industries, probably as a result, which we can't quite see at the moment because of the furlough. And the pattern of that, I don't know about. That's not really my domain, but I think that's obviously got to be tracked, and I suspect that maybe the IFS, the Deaton inquiry, will be doing just that, particularly the hospitality industry, which is obviously hiring, it's taking up a lot of youth employment. So I think that's the thing to watch. On the virtual side, I mean, what COVID may well have done is accelerated what would have happened anyway with respect to new forms of working, and the move in particular to hybrid working. Now, this could be painful as we readjust. Obviously, some places will lose out because high streets and all the rest of it, as you say, where people had congregated for employment, may be sparser than they would have expected. On the other hand, it could be that some other areas that were sparsely populated could be seeing the benefit. And as people move to areas which are more rural and in which the quality of life is good and the housing stock is cheaper, that may well lead to a resurgence in those communities. So the question in my mind is how is this going to be handled? Is there going to be some kind of management of this? Is there going to be some sort of tracking of this in order to understand what's going on? Because as we know, where there are sudden changes of this sort to the economy, there can be very significant and avoidable damage. I mean, the very obvious, probably too simple example is the destruction of the mining industry, where that really happens so fast with no help at all for those mining communities. So is there something that can be done through the Levelling Up Fund, through the infrastructure, that can somehow address that and smooth an inevitable path? I think so. Just as we're going to have to do the same with the green revolution as well, to try to smooth that path away from dirty to green industry. So it's a question about more intelligent government, and that in turn leads to what is the role of the state? Is the state just to leave it, or is the state to smooth it, to try and smooth over the social and cultural hurt that will happen, and get us in a better place? Thank you.
Great. Vital or Joan?
Can I just lead on from that, because I've had similar comments, but if you think about, again, Marmot's view, you've got to tackle, I think Vital mentioned this as well, you've got to tackle climate change as well as well-being to hit health inequalities, which is what we're talking about today, right, and post-COVID. So 11 of the 17 Sustainability Development Goals are about health inequalities. Right? People think climate change, spec, kit, cars, 11 of 17. So the realigning that Jennifer talked about between what our economic, what's the strategy for growth linked to well-being has got to be aligned, most certainly. But the regeneration picture is interesting because, again, that concept of anchor institutions, local people, local economies and growing local economies. What did we have pre-COVID? We had big town centres and big towns, frankly, thriving, outskirts, outlets, whatever you want to call them, people working from home. What I'm seeing in my local area is more opportunity for people to shop on the local high street in the local town centre. And so that, we're not saying you want to have everybody not in the big cities and in their local centres, but there's certainly opportunity for regeneration. And probably that's where your question was leading. And again, thinking that through. And lastly, the workforce, they will choose. So our strategies will now have to actually take account of where they're going rather than where we tell them to go.
Vital, did you have any thoughts on this?
Yeah, so I think both Jennifer and Joan have kind of covered most of the things that I'd have thought of. One thing that you'd raised was issues of mental health. So I do think that during this process, there's likely to be potentially significant job losses, disproportionately affecting young people, probably also disproportionately affecting low-paid people who are already at greater risk of poor mental health. We know that there's things we can do to try and mitigate some of these harms. So in particular, active labour market policies, trying to make sure that people can find alternative employment. But I'm not sure it's necessarily a wholly bad thing. I think that the suddenness poses challenges that need to be managed, but a move towards potentially greater localism could in theory help us contribute to addressing the climate emergency and reducing greenhouse gas emissions and so forth. So I think we also need to think about what the opportunities are during this realignment, but it needs careful management.
Yeah, I think that's right. So we've got a number of questions in the Q&A function, but I just wanted to ask one more question. So June mentioned sort of the deaths of despair and how that might have played out during the pandemic and afterwards. Now, my understanding on the sort of deaths of despair, and in particular the suicide aspect of the pandemic, is there was quite a lot of concern a year ago that lockdown would lead to an increase in suicide rates in the UK. And my understanding is that hasn't sort of materialized in the data yet. And I'd sort of be quite interested to understand why you think that might be the case. And is there something that may be a problem that comes further down the line if it's not materialized over the past year? So
I suppose going back to my point earlier about the importance of job losses. So we know that job losses are a really important predictor of suicide. So thanks to the furlough scheme, which I think in many ways has been really excellent, it's helped keep people in employment. It's possible that people's mental health might have been relatively protected, and certainly that's what we've been seeing in some of our initial work looking at the furlough scheme. But as that gets withdrawn, trying to make sure we don't have lots of people losing their jobs very quickly without support, I think is going to be crucial to try and prevent the uptick in suicide, which I think there is a real risk of.
Just a small point from me. I think also, you know, that lag rate. So we know that alcohol use has steadily increased. And what's the lag until you kind of get to that deaths of despair that Michael Marmot talks about? It is pertinent in any health inequalities work. It was a very specific grouping as well, that 45 to 49. That's really interesting because usually it was younger people who were at risk of high rates of suicide. So again, I think there is some lag. And the differences in Black and minority ethnic communities, that the jury's really out as well. And unfortunately, we already know the rates of ill mental health and the way in which particularly Black men are incarcerated in secure wards at higher rates than any other community. Again, what are the strategies people might be using to avoid that? And then when does that come through the lag? We just need to be really quite listening and acting on what we know will happen in a positive way for those communities.
Thanks. Just quickly to add, obviously, as Vital says, the furlough has sort of shielded, I think, quite a lot of people who may then be suddenly exposed to stress, hence the need to tail off the furlough as opposed to a sudden cliff edge, as people have said. As Joan says, the deaths of despair have always been there, as we know, in terms of the stalling life expectancy is particularly an issue in that younger age group, as Joan says. And in particular, males, and in particular parts of the country, that's where the health has eroded the most over the last 10 years. And it's that particular group that is most at risk of deaths of despair, in part because of this sort of economic malaise that Deaton talks about. What we don't know is we know that unemployment is associated with suicide, so we will expect to see that as time goes on. So I suspect the furlough may uncover it. The other last very quick point is that often in cases of extreme stress, it is not at the most stressful time that this happens, it's afterwards. So I think that's the other thing to worry about and monitor. Thank you.
Great. So Suzanne Masham has got her hand up in the audience. So Susan, can we invite you to speak and ask your question, please?
Yes, there is concern about the shortage of intensive care beds and trained staff. We were short of these before COVID-19, and it must be even worse now. Compared to Germany, we really are understaffed, underbedded. This holds up serious operations. What do you think can be done about this?
Would anyone like to tackle that one?
I'll start. If you can almost say there's a positive thing about COVID, it's really showing up the starkness of the difference in intensive care beds and how we need to fix that. And certainly that is absolutely on the radar and is being acted upon practically. The longer work of how do we recover as a system and the effects on staff, it's kind of a double-edged sword, isn't it? As the question has just said, you know, if you think about, yeah, let's get back to making sure people can have their operations and their interventions quickly, those same staff are the people who have been overworking for almost a year or over a year. How do we align that? Because we may not have any staff if we keep on at this rate. So, and I think there is a public discussion that needs to be had in that respect.
Thank you. I think a couple of things there. I think the first thing is our long-term planning is not strong. Even in, you know, as I said, Britain's biggest industry, we don't really have, in fact, there are now calls for proper independent projections to be made of the staffing that we need and the beds that we need in light of future demands, likely demands on the health system. Both in terms of normal business, but also in terms of potential insults. So that requires planning, it requires horizon scanning. And then quite frankly, we need to price in resilience and spare capacity, which we haven't done. We've kind of had a just-in-time kind of mentality because of short-termism, but we can't do that as this shows. So I think how you do that in an economically constrained world going forwards in Britain is a moot point, but nevertheless, we know we have to do it. So I think we can't get away with living hand to mouth in the way that we've done. We need some proper planning and, as I say, pricing in and subsidy for resilience and spare capacity. Thank you.
Yeah, I think you've hit on a really important issue here. So many years ago, I used to work in intensive care, and the impression I get is many people are fed up, quite frankly, over the last year. And I think we need to appreciate that actually training intensive care staff takes a long time. So I think we do need a much more longer term strategy, but also we need to think about how we're treating migrants to this country as well, including healthcare workers. So I do think there's more that the government could do to provide reassurance to healthcare workers and in terms of making the NHS a good place to work, to address the short-term deficits as well as a longer-term strategy.
Thank you very much. I think in the new health bill that's coming along, we ought to try and press for this.
Great. Well, thank you very much for your question, Susan. Can I now go over to Joe Clark, who's posed a question about generations into the Q&A. So Joe, can we invite you to ask your question, please?
So for me, there's a huge distinction between, if you like, the generations, for want of a better word, those who are already living with the long-term conditions and that burden of disease, those whose life circumstances are heading in that direction, and then those on their path starting out who haven't kind of chosen one way or the other. How can that be incorporated into national and local strategy and policy?
Anyone want to tackle that one?
Again, just very briefly, so this is really the health inequality strategy that we talk about, isn't it? And we've talked about for a long time, but not done. The life course planning, the way of looking at life courses and planning healthcare accordingly. We started and stopped that, didn't we? Is it time to finish it? And we were looking at that kind of life course activity from 2010. So absolutely it needs to be done. But again, it needs to be strategic. It can't be blocks of action in various parts of the UK.
Thank you. I think that's a really good question. And what we need to do, don't we, is to shift the distribution curve of ill health, if you like, so that we can prevent earlier in the life course, just as you say, before the risk factors start and before comorbidities amass. And we know that there's a 19-year gap between people who are in the poorest quintile get sick, or at least get comorbidities in their early 50s, and people in the richest in their early 70s. I mean, it's that stark, as we know. There's a lot of work and research and skewed effort on comorbidities. There's some on risk, government's obesity strategy. We could be a lot more proactive on tackling the risk factors for obesity and other illnesses. So there's a huge opportunity for government policy to be more proactive on that. And just as Joan says, when it comes to the young, and we really need to be far more active on the wider determinants of health, and that includes early life experiences. It means early life support. It means a lot of things that local government are responsible for: housing, crime, education, green spaces. All of these things add to health capital and are protective effects against the risk factors, which then lead into the illness factors. That's what I was saying about the government needs to be a lot more serious about an inequality strategy, which really goes hand in hand with local government and probably business as well. Just one last point, if I might. If you look at the government at the moment, the prevention strategies, the flavour of those is very much on individual behaviour change and technology. It really, really isn't on the wider context that is leading to sickness and weathering people's health fabric, if I can put it that way. And I think that's an unfortunate focus of prevention. It really is not going to do the kinds of things that the questioner is asking. We really need to tackle this upstream thing. And you know, so I think there's again a cognitive bias. You know, just if individuals just behaved better, you know, didn't smoke so much, didn't drink so much, weren't so risky or chaotic in their lives, all would be well. That really is just so limited. And I think we've got to get out of that cognitive bias within prevention strategy. Thank you.
Yeah, so I think exactly right there. One thing I would add to that is actually to do that, what's probably needed is thinking quite seriously about the government taking much more of a leadership role, potentially thinking more about regulation rather than always relying on expecting individuals to take up healthier behaviours. So we've seen, for example, the sugar drinks industrial levy, which I think has actually been a really good example of actually how some of the actions that would be needed to try and tackle obesity amongst the next generation, but it needs to go much further. So we know that the things that are most likely to make a difference, especially in terms of health inequalities, are more regulatory approaches that are targeting price, marketing, and availability of potentially unhealthy commodities. So things like alcohol, smoking, alcohol, tobacco, and sugary foods and so forth, which does require government leadership.
Thanks, Vital, and thanks, Joe, for your question. We've got an interesting question from Amy Norman on use of technology and things like digital consultations and how that might impact health inequalities. So, Amy, would you like to ask your question?
Hi, yeah. So the pandemic has been a catalyst for the uptake of digital health and tech solutions such as phone and video consultations. Do you think this will be a long-lasting effect, and what impact could that have on health inequalities, particularly thinking about the digitally excluded?
So would anyone have any thoughts on that topic?
So I think you're right, there's a real risk with digital tech, but we also need to be much better at not just accepting digital exclusion as well. So I think increasingly many services are being delivered digitally. So for example, many welfare benefits are increasingly expected to be delivered digitally. So we need to make sure that there's a strategy to ensure digital inclusion, both in terms of actually the infrastructure, making things affordable and providing people skills that they might need, but also for ensuring there are alternatives in place in terms of services as well. One thing I would say is to express a note of caution about the assumption that a kind of a digital or tech-based approach is necessarily better. So I think for many health interventions, while we might get quite excited by the new Fitbit or whatever, actually the real capacity to improve health, I think, needs rigorous evaluation. And often a lot of high-tech approaches may not actually deliver on their promised health benefits. So we do need to quite robustly evaluate some of the new technologies that are coming on stream as well.
Jane or Jennifer, did you have any thoughts on these technologies?
Yeah, quick one from me. What do we mean by digital? It's an interesting concept. We know that, so if you look at some of the digitally excluded communities in the sense of either age, population, or Black and minority ethnic communities, we know that over 90% of those communities have digital phones, increasingly, have always. So what is our concept of digital, and have we asked people? And then what's best for use on that kind of platform as well as others, and what then frees up space for our clinicians, and frankly, the 90% of clinicians who don't work in hospitals but work in primary care and allied health professions, who can actually act on health inequalities and want to, but they have had their time and space taken up with consultations that could have been better done on a digital platform. That's where we're finding certainly some of those practices will stay. Local areas are saying, we had 5-year clinical strategies to escalate digital use. It's here now. But the important thing would be to carefully and in a segmented way, locally work with communities to see what works and what doesn't. That will be variable.
Thank you. Just to say a couple of extra words. Everyone's mentioned the digital divide, and obviously you'd be worried about systematic biases there. There's something about digital medicine or healthcare, which is very transactional. And actually, a lot of what we've been describing, particularly with respect to the interaction of poverty in health and wider social stresses on health, you need to know the family, you need to know the history of the person, you need to know lots of factors about them, which doesn't really get well served by digital. Digital is like a consumer transaction. It's not really about healthcare, which is far more holistic, to do with the patient and their context. So I'd be slightly worried about, whole scale, unquestioning move towards a lot of digital, because a lot of what we see in healthcare is the whole patient and the whole context. So that there's also other issues about the use of digital and artificial intelligence bias with algorithms, looking at the risks of individuals that are too biased towards certain groups more than others, depending on who's using digital and where the data is coming from. So I think all of those need to, but there are huge opportunities of digital as well, which we shouldn't forget, and also not just individual collective opportunities, but collective if that data can be used to look at the health of communities, for example, in more granular detail. So I think there are opportunities, but I think the idea of we can move cheaply away from more holistic healthcare is I'm afraid, for the birds.
It's an interesting thought, Jennifer. Can I just ask a question that sort of builds on Amy's question? And One thing that we explored in a recent SMF paper on obesity was a sort of the gendered experience of getting help for obesity, and in particular, if you look at the data on some obesity treatments, there is a big difference between men and women getting treatment. In particular, women are much more likely to get treatment than men are, and I think a general issue across quite a lot of medical issues is men are quite reluctant to get help sometimes, or they're reluctant to go to the GP, they're reluctant to see the dentist, and so on. And is there potentially some scope for technologies to help in sort of narrowing that gap in between men and women seeking medical help?
Yeah, for some people it will increase barriers, digital, and some people it will reduce barriers. But I think for this it leads back to, so in a sense we should be exploring that, and I think there are opportunities. But I think the thing about digital though is that it's personal and transactional, and that's the worry. So even if the bloke finally does seek help for obesity, it's the fact that they live in a food desert area, it's the fact that they're living on their own, they don't like cooking, can't cook, or they haven't got the money for the gas meter or whatever it is, you know. So and digital is not going to really help with that.
I was going to say that the whole aspect of why people are not looking after their health, and I think Alicia Weston, she's putting some stuff in there. So again, we're doing the fixing without understanding the why and doing the deeper work. And so the relational aspect of what we need to get into grips with will then help us deal with, you know, what do we then need to fix this? But we're going straight to here, let's use digital to fix, when we're not understanding some of the more endemic problems in communities around, you know, just so many indices, and who we don't talk about a lot of migrant communities. During COVID, you know, this fear of just using any public service because of this hostile environment, and have to use those words we created for people. It's not healthy, and it doesn't this is a public health issue of COVID. So we want to engage as many as possible towards use and towards, you know, a recovery. And that certainly needs relationship building. To be clear, I'm suggesting definitely digital can help, because it then frees up space for those relational interventions that need to take place that we don't have enough of at the moment in our system.
Great, thanks, Joan. So we've got an interesting question from Alex Wall about the communities that are refusing to take the vaccine at the moment. Alex, can I invite you to ask your question, please? Alex is still there. No, I think Alex isn't there anymore. So Alex's question was on the point about communities that are refusing to take the COVID vaccine, and what can we do to resolve this issue and start what he or she calls the long fix work.
So I think that there's the long fix is a really apt way of thinking about this. I think a lot of the drivers of people's reluctance to take up the vaccine reflects quite long-standing processes. So we know that, as mentioned, the hostile environment policy, the way the Windrush generation has been treated, the history of the inclusion of ethnic minorities within clinical research, including lots of research which would have never been done on white people, quite frankly. All of those have contributed to some extent, a mistrust in some of the information that's been delivered. There's also been so I think a lot of that longer term work is definitely needed, and ultimately that's what's going to be the most important in terms of long-term health. In the short term, we need to be better at working with communities, relying on kind of trusted local leaders to communicate messages about vaccination. But we also need to be better about listening to what people's real concerns are. So actually, often the concerns are amongst, for example, minority ethnic communities are similar to the majority white British population, and they're perfectly legitimate, understandable concerns. They're concerns about, well, what are the long-term consequences of taking a vaccine, since, you know, the vaccine's only been around for a relatively short period of time and so forth. So I think we need to try and answer people's worries as directly as we can. So we need to explain, for example, in terms of that concern about long-term consequences, well, that's true in terms of this specific vaccine, but actually the vaccine's been built on previous vaccines, which we have a long history of working with. And we need to weigh that up against the risks of COVID itself, which is a very, very serious disease. So I think, you know, all of those elements are probably needed. And we also, the last point I would make is ensuring that vaccination is easy for people as well. So some of the invitations based in kind of big vaccination centres and so forth require people to travel significant distances, which if you don't have a car or whatever, can be quite difficult. So actually trying to make vaccination as easy for people as well is an important part of the picture.
Can I just come in and say a couple of things? So let's just be clear about the picture. Since COVID, we're popping up on screens for a significant number of those people who are dying in Black and minority ethnic communities look like myself, Vital, and they're popping up on TV screens before anybody actually starts to really recognize the problem. It's a global pandemic, okay, fine. So staff who were not protected adequately, dying in numbers, bear me. Community members were dying in numbers. People, pregnant women, any community dying in numbers. Then we're asked, protect yourself, please come and work in the worst public-facing roles at a time of COVID, because they're customer-facing roles. Because of the economic issues, we understand people on 0 hours contracts, not paid a lot of money, going out to work, risking life. We then come to February or March and we say, please come be first for a vaccine. I mean, you know, we just really need to understand that this is not a lack of, can't be bothered, you know, don't want to. These are real issues. And I've just talked about last year, not the last 60 in this country, of why the trust has been broken. We have an opportunity to really engage with that. And by the way, pregnant women of all, you know, of all ages are very worried and not taking the vaccine in numbers. People with learning disabilities in all communities, and young people. So we just need to, I think, level out the information we're even hearing and deal with that, rather than this constant refrain of those communities don't want to take a vaccine. It's not helpful.
Jennifer, did you want to add anything to that? No. So my colleague Jake Shepherd's asked a question on well-being and health inequalities. So Jake, would you like to ask your question?
Hi everyone, can you hear me?
We can, Jake.
Good. So the pandemic has showed us that our health and our general well-being is of course deeply important. And earlier there was a discussion around social and green prescribing, and mental health was also touched upon. I'm wondering about well-being and the extent to which that should be integrated with or into government policy. So in your view, this is an open question to all of you, what potential does a focus on well-being have for reducing health inequalities, and to what extent should it be a policy objective? For example, should the UK adopt more of a distinct well-being strategy? I'd be interested to hear what you think.
Thanks, Jake. Would anyone like to tackle that one?
Perhaps if I can make a start. I mean, it's a really good question. There's been a lot of talk, hasn't there, in over the last few years about what's called the 4 capitals, which is sort of based on the New Zealand example and the government's approach in the New Zealand to think about well-being and the prosperity of the nation. moving away from measures of economic and infrastructure capital, as it's called, to measures of human capital, measures of social capital, and measures of natural capital. And I think we're kind of getting that, aren't we, with the natural capital, at least with respect to net zero, because the government, in addition to its plan for growth that it published last week, also has published a 10-point plan for a green industrial revolution, in part because of international pressure as well, has to be said. But if you look at the documents that I saw in the plan for growth, as I was saying earlier, they're very skewed towards infrastructure and economic capital, and they don't really feature well-being capital or health, human capital, which includes social capital as well, the health of communities or the vibrancy of communities. And we know that, you know, the Brexit vote and the divisions showed that there are huge cultural issues across the country, weren't there, that maybe need tending to. So I would like to see in across government policy a far more balanced approach across not just central government coming out of Cabinet Office and the Treasury with respect to growth, but in terms of other big departments of state. What are they planning to do, and how are they addressing these four capitals? You know, and if they are skewing towards one or another capital, then why is that across government? What does it? I mean, it just seems, and the reason is not because that's just the right thing to do, because it's more balanced, but because all of these four capitals are completely intertwined. The idea that you can have a prosperous Britain without having a healthy Britain is just, you know, it's just not borne out by the evidence, quite frankly, because you don't get productivity is affected by health. So, I you know, there are steps that are being taken. At the ONS, for example, is now trialing, isn't it, its well-being index. OECD is talking about these four health capitals, World Bank, IMF, and others, as well as New Zealand and a few other countries. And I just think we just need to, we don't need to be Puritan because we're just beginning, but I think if we were able to just balance our approach a little bit more to these four capitals rather than just one, and also towards a little bit more to do with the longer term and away from the short term, I think we'd make some progress. Thank you.
Thanks, Jennifer. So Councillor Neil Nervers asked a question sort of following on from Jake's question, which is about where does local government fit in all this, and how can local government use agency to enable operational NHS to address local health inequalities? So where does local government fit into the picture?
Sorry, I was going to say that agree with the premise of the question, as does Marmot. He reiterates we need well-being and climate change in any cross-governmental strategy. I just wanted to focus on what we mean by well-being. So for local authorities who have a wider range of services to connect with local people, there's that obvious role for escalating community action, where we escalate that in a positive way. It's usually seen as negative. There's something called Incredible Edible, some of you may have heard about, and it talks about growing your own and kickstarting local economies. Big role for local authorities there. The impact of loneliness, discrimination, including racism on well-being is documented both in Marmot and in Marmot's report and other places. Let's tackle loneliness. Again, local authorities have been doing more on this. So again, these definitions are a tried and tested evidence basis about how we tackle well-being across our public services.
Great, thanks, Jane.
Sorry, can I just add one thing there? In terms of the health of the nation, the healthcare really only addresses a very tiny bit, as we know. It's less than 20%. 80% of it is these wider determinants, which are much more within the agency of local government. The background context is not very conducive at the moment to supporting local government, in that you know, there's a lot of mismatch in central local power, which hasn't yet been addressed as discussed, but local government does have a key role in local regeneration and prosperity that can affect, not just in its role to shape public services of the type that affect health, but also in its leadership role in convening partners that can help to spot them and work together. So the voluntary sector Joan mentioned, the NHS as an anchor, very important, local businesses and chambers of commerce, very, very important, and universities, and the possibility there of all sorts of cultural activities and also science development. So I think local government in its leadership role, in particular those areas of the country where local government has critical mass, and this is why devolution is so very important. So GM, Greater Manchester, covers 10 local authorities. That really does allow a strategic mass of leaders together to really do something at scale, which is what's needed. And until we get the local government devolution and recovery bill, in a good shape, I'm afraid it's down to local government leadership locally.
Thanks, Jennifer. So I think we've got time for one more question. So Richard has posed quite a meaty question around how prepared the state was in advance of the pandemic. So Richard, can you please ask your question? Or I can read it out if Richard isn't able to speak. So Richard's question was around the extent to which the state wasn't prepared to deal with a SARS-based pandemic such as COVID, and to what extent was this sort of poor preparedness a cause of us being in the situation we're in at the moment? So do the panelists agree that this has been a key reason for why the UK has coped poorly in the pandemic? And what do we need to do in place going forward to ensure we are better prepared for future pandemics? So quite a good question to end on, I think.
So in short, I think, yes, the UK was relatively poorly prepared. The issue of being prepared for pandemic flu rather than SARS, I think probably did play a role, but to be honest, I don't think it's probably the really key factor. I think delays in terms of kind of locking down early on were probably quite important, and that I think there's been, to some extent, too much of a way of thinking about the pandemic as health versus the economy, which I think is quite unhelpful. Often, actually, what we've seen both during this pandemic, but also through looking at the historical evidence, is if you act early to try and keep people's health intact, then actually the economic benefits will flow from that. So I think if we'd been more interventionist early on, then we would have actually probably had a stronger economic recovery than maybe we've been experiencing. We have also had big quite significant budget cuts in terms of local governments, but including public health as well. And I think this applies more to England, possibly, than some of the other nations. But I think that's meant that actually the capacity of public health to respond hasn't been as great as you might have hoped. There's also arguably not been as much of a leadership role for public health as probably there should have been. So I think there's been a very centralized approach to tackling the pandemic, and the role of local public health expertise has probably not been valued as highly as it could have been. And then separate from all that, we also have the lack of long-term funding in the NHS as well, which also pose challenges.
Yeah, I think no government around the world probably comes off very well, does it? But I think a couple of really big things for me. I mean, there's obviously a long list, and hopefully there will be an inquiry. I think this has shown up challenges, weaknesses in the way that we face uncertainty which can produce big risks like a pandemic, but also probably uncertainty with respect to huge opportunities that we fail to see and grasp. So how we can become much more intelligent about seeing and anticipating a whole range of risks and opportunities in future, given that the future is uncertain, I think. So that goes into horizon scanning, it goes into, the sort of, as I was saying, the kind of cognitive biases around which mean we are blind to certain things. So there's a lot on that. And actually, there's a very nice book written by Mervyn King and John Kay on managing uncertainty with respect to the financial environment that I think there's some interesting lessons there. And the second thing I think Vital has sort of mentioned is even if you have a really good horizon scanning apparatus and can think about these things and have the imagination to think about them, which requires space and investment, it is the decision-making apparatus we had in central government. It just has to be looked at, doesn't it? And as well as the central local, but within central government, it looked pretty ramshackle, didn't it? And then, of course, there are separate questions about the NHS, which I could go on at length, but I will stop. But there is a lot of stuff about preparation there too. But I think those two big things are really, it just looks, we look, just one thing, a hope thing, we have invested in science, we have got vaccines. So it's not entirely global. There are some areas of hope that we can learn from. Thank you.
Jane, you're going to get the last word. So
yeah, so a couple of points from me. I love the phrase building a public infrastructure. I mean, we need the clinical one. We spend a lot of time there. Building that public infrastructure is key. And across the UK, there has been disinvestment in community organisations, professional bodies who know what they're doing when it comes to engaging people. So can we build that back when we think about all the other issues and the investment I talked about before? 150 billion just in England and over 220 or 30 in the rest of the UK is quite a lot of money. So not being flippant about that, how do we reuse some of that money where we take the opportunity through the integrated care bodies and partnerships to work with partners at that neighbourhood and local level, where decision making can be again a bit more focused on the people, will be important, and it gives an opportunity to do things differently.
Great, thanks, Jane. And I think that was a really, really good question to end on. We have run out of time, unfortunately. So first of all, thank you very much to our panelists, Joan, Jennifer and Vital, for their contributions and for answering all the questions and for those presentations at the start. So thank you very much. And thank you to everyone in the audience for attending this event. And hopefully you will attend our future events too. So thank you.